Welcome back. This is third part of our lecture on genital prolapse. We will continue to discuss how a patient can present clinically if she has genital prolapse. We discussed already the first slide, and the patient may present with rectal symptoms, especially if it is procedentia, like it's the full-fledged uterus has descended. So in this case, patients may have constipation and they may need to manually digitate, replace the prolapse before defecation. They may feel heaviness in the rectum and constant desire to defecate. Okay, and hemorrhoids may develop from straining. There may be back pain, and there may be associated decubitus ulcer and with associated discharge, or there may be some bleeding as well if there are ulcers. So how to diagnose? Careful inspection, and that's the key. Okay, so a full-fledged examination. Of course, we will perform a general physical examination, then abdominal examination, superficial abdominal examination, and then we have to carefully inspect vulva and vagina to identify erosions, ulcerations, or other lesions. The extent of prolapse should be systematically assessed. Some women can have urinary incontinence associated with prolapse. So when we are inspecting even the patient, first is we have to ask, it can be in the standing position, and then on lying down in supine position. So when we inspect, we also notice for any urinary incontinence. Suspicious lesion should be biopsied, because very rarely, if there is an ulcer, it can be cancerous. Now on palpation, actually, so actually a part of inspection is doing a speculum examination. And which speculum do you think we use if it's a prolapse patient with prolapse? Actually, it's the Sims speculum, not the Cusco's speculum, because these blades of Cusco's, they hide. For example, if it's an cystocele or rectocele, we may miss. Okay, so the better one is Sims speculum, and the best position is the Sims position. So Sims position is actually kind of left lateral, or like patient is towards on one side, and then we can use either of these blades. Okay, and they can be turned around. So for example, if we want to see this one is for to see cystocele, right? Ask the patient to cuff and see whether we see a bulge, and then this blade is placed here, and then look at the posterior wall, cuff again, and then the patient has to cuff again, and we see whether the posterior wall of the vagina, it is bulged. Now the maximal extent of prolapse is demonstrated with a standing and straining examination, which means ask the patient to stand first and then give a cuff. Pelvic muscle function should be assessed after the bimanual examination. Then once we have performed this, we have to perform bimanual examination as routine. If it's a procedentia, then replace it, right? So push it back and then perform a bimanual examination. And then resting tone and voluntary contraction of the anal sphincter should be assessed during rectovaginal examination. Okay, so that there is a staging, there's a grading thing which is called Oxford grading. But if it's a full-fledged uterovaginal prolapse, then we have to assess the rectovaginal examination, which is the rectal examination. Now, what are the treatment options for a woman with prolapse? It depends on the severity of the prolapse. Sometimes, if it's a just early stages of a cystocele or rectocele, it may not need any treatment. Okay, so but depending on the situation, first always start with conservative treatment, which and the first line is pelvic floor muscle exercises. These are called Kegel exercises. The patient, ideally they should be supervised, which means there are physiotherapists who with interest in like pelvic, who have expertise in providing services related to a pelvic floor. So how does it help? It reduces the symptoms of prolapse for early stages. In later stages, they are usually not useful. Then there is something which is called vaginal pessary. Okay, they are different types. We will discuss about them later, but they basically push the prolapse back. They help the prolapse to be in its normal position. And then, especially, for example, if a patient is unfit for surgery, or even if a patient is pregnant and they have prolapse, because sometimes young women can also have prolapse, so they can use a pessary. So it basically avoids the need for surgery. It can be given as a trial even before surgery. So different types and shapes of pessaries, which we will learn about later. So physiotherapy is mainly Kegel pelvic floor exercises. It is basically like telling the patient to, as if she is holding her urine or stool actually. Okay, so it's like that, and she has to do it many times. And the physiotherapist may use vaginal cones of increasing weight. Okay, so they may put it first vagina in the vagina, a smaller one, a lighter one, and then the duration and the weight of the cone can be increased. It's basically like to hold the cone, right? Vaginal cone. And it's an exercise for the pelvic floor muscle. Now, it's also called, maybe in books, if you read books, then you will come across this word PFMT, that's the abbreviation for pelvic floor muscle training. They are like clench and release exercises that make the muscles of pelvic floor stronger. But before that, bladder should be emptied. Urinary bladder should be emptied, and the patient is asked to tense the muscles in pelvic floor for a count of 3, then relax them for a count of 3, and then 10 repetitions. You do not need to remember this. And goal should be to do 3 sets of 10 repetitions every day. Okay, so it's just repeated contractions of the pelvic floor muscles so that they are strengthened. Now, talking about the vaginal pessaries, they come in different shapes and different sizes as well. But we will talk about the two most common used so we have slides coming up. Now, when should pessary be used? It can be used during pregnancy, because during pregnancy, if there is a prolapse, it's not operated upon. Okay, because during pregnancy the intra-abdominal pressure is very high, right? There is a big baby and a lot of fluid and rest of the things. So even if it is operated upon, it's more likely to fail. So that's why prolapse surgery is not performed during pregnancy. It's the same like varicose vein surgery is not performed, or hemorrhoid surgery. Ideally, it should not be performed during pregnancy. Okay. Then it can be used during pregnancy or immediately after pregnancy and during lactation, because it takes some time for structures to go back to their normal size. When future childbearing is intended in near future, okay, patient's refusal for surgery, or the patient is unfit for surgery, for example, general anesthesia, unfit for general anesthesia, as a therapeutic test, which means even before surgery, if a pessary works for a patient, most likely surgery will work for her. Okay, to promote healing in a decubitus ulcer. Decubitus ulcer was as we discussed earlier, I showed you the picture. If it's procedentia and there can be ulcers. So when there is an ulcer, it should not be operated upon, because there are increased chances of poor healing infection. Okay, so first it needs to be healed. And how it is healed? Yes, pessary will reduce the venous stasis, right? But the patients also need packing, vaginal packing. Okay, now, two important types of pessaries. The first one, which is very commonly used, is that's called a ring pessary. Okay, that this is how it looks like. Okay, so it should be made of silicone. That's the better material, and the cheap materials, they can cause complications. And they come in different sizes, but a good sized perineal body is required. Right, perineal body should not be, perineum should not be deficient. And the good thing is, even if the woman is sexually active, it does not interfere with sex. The other type is called gel horn pessary. It's used for women with deficient perineal bodies, but it interferes with sex. Okay, so how it is placed actually? So this is squeezed. This is squeezed. It comes in different sizes. So first we should know the total vaginal length of the patient using fingers or measuring tape, whatever you are using, and then it is squeezed and pushed into the vagina, If it is too tight, what will happen? It can cause urinary retention. Okay. But if it is too loose, it can fall out. Okay. And okay, I think we have what are the possible complications? See, this is sometimes because most patients in urogyne, they are old women, okay, senior people. So, and they may have problems with memory, so they may have dementia, especially if there is less support, or if they do not have anyone to take care of them at home, they may forget about this pessary. So once a pessary is inserted, it should be cleaned, taken out, cleaned, washed, and placed back every 6 monthly. And some women can forget that. Okay, so and it can erode the surrounding structure, especially if it is too tight, and if it is forgotten, it can cause fistulas even. Okay, but some of the complications may include vaginal bleeding, vaginal infection or discharge, constipation, urinary incontinence, so or even urinary retention if it is too tight, incontinence if it for example is a vaginal fistula. It can cause infection. This is bacterial vaginosis. Okay. And actually, it can cause even ulcerations, infection of the cervix, rarely carcinoma of vaginal wall. It can be impacted, so it can erode into the surrounding structures and it can strangulate the prolapse tissue, rarely rectovaginal vesicovaginal fistulas. Now, I will, I think, stop here. And in the next part of the lecture, we will discuss the surgical options.